Good afternoon, everyone. I welcome you all for the 10th lecture series for the standard treatment guidelines, which was started on the month of September 2022. I welcome the participants, our guest speakers, and I also extend my welcome to Major General Professor Atul Kotwal, sir, Executive Director, NHSRC, Dr. Jain Srivastav, sir, Advisor, QPS Division, NHSRC, for this lecture series. I also welcome the Dr. Babita Gupta, Professor from the AIMS, New Delhi, and also I welcome Dr. Sangeeta Sharma, IBAS, New Delhi. I request Dr. Jain Srivastav, sir, to address the participant and brief about the objectives of the lecture series. Over to you, sir.
Thank you, Annapurna, and very good afternoon to all the delegates, those who have joined remotely, and our expert of the subject, Professor Babita Gupta, and of course Dr. Sangeeta Sharma. And we are privileged to have our Executive Director, General Professor Atul Kotwal, joining today. In fact, we are privileged to have you, sir, because I know that you are having the competing priorities, but still you have taken time out to be with us. It is a great honor and privilege. Today is the 10th lecture series, and about 120 participants are logged in. And we are also aware that at many locations there would be more than one participant will be listening. And this lecture series was started in collaboration with the Delhi Society for Promotion of Rational Use of Drug and NHSRC together to strengthen the kind of prescriptions that are being generated at the peripheral health setups, namely primary health center, community health centers, district hospitals. Because we know that irrational prescribing is quite rampant all over the country, even in the Western world. We were, besides this, we also wanted to club with the relevant clinical topic, and today is the 10th one. And today's topic is so relevant. We all face this challenge of sudden happenings where there is a need to administer cardiopulmonary resuscitation, whether within a healthcare setting or outside the healthcare settings, and where all of us feel challenged. And so without further ado, I would request our chief guest, Major General Professor Atul Kotwal, to deliver the address, and then subsequently we can get on with the technical session. There will be two technical sessions. Initial technical session is on the polypharmacy, its peril, which Professor Sangeeta Sharma will be talking about. And then, of course, cardiopulmonary resuscitation, its quality issues, its effectiveness, measurement, on other related dimensions, Professor Babita Gupta would talk. Before I stop, I would request all the participants that whatever your queries, questions, clarifications are there, please post in the chat box. Somebody is writing it down over here so that we are able to address, club them together, and the experts are able to address over there. So thanks very much, and I would request our ED sir to deliver the address.
Thank you, Dr. Jain Srivastav, sir. Good afternoon, everyone. I hope I am audible.
Yes, sir.
It is audible.
Okay, thank you, sir. Thank you. So, good afternoon, everyone. All those who have joined, and really heartening to see, that a large number of the specialists, medical officers, staff nurses, CHOs, and even a lot of nodal officers from states join these alternate Saturday series on this initiative by the DSPR, UID, and NHSRC combined. So I must commend Dr. Jain Srivastav, sir, his team, and Dr. Sangeeta Sharma. I think you are a one-person team, and but again, that is very, very strong. And so this, I think, it's standard treatment guidelines. The importance you all are aware, and Dr. Srivastav sir has already alluded to that. And a very good afternoon, Dr. Babita Gupta, also Professor in Physiology of JP and Trauma Center on Institute of Medical Sciences, who is our expert for today. Today's topic actually is extremely important, not only for our practice as such, but if you see that now in the comprehensive primary health care package, the emergency care is part of that. So earlier we never thought emergency associated with the primary care. We always thought emergency will be, will always be dealt with as secondary, tertiary. But unless and until everyone is aware that how to deal with the emergencies, and the golden hour principle will not be followed. And the initial resuscitation which is required, that should be known to everyone. It should now in fact, after these efforts, it's time to go outside to the community also, beyond the health sector as such. So this cardiopulmonary resuscitation, that is today's topic, which Dr. Babita Gupta will be delivering her talk subsequently. We all know it's a life-saving technique which is useful in several emergencies. It could be myocardial infarction, it could be drowning, it could be electrocution and certain effects of that. Any such event, and where the breathing or the heartbeat has stopped. So and the victims require immediate CPR to prevent the damaging effect of lack of blood flow to the vital organs of the body like brain, heart, lungs, and other organs. So the with every minute of delay, the survival reduces by almost 7 to 10%. So that's why initial CPR is very important. That's why I must reiterate that it is our healthcare workers' duty that not only to train ourselves in this, but also go beyond and train even the general public also in the appropriate, correct way of of CPR. There's a lot of videos also all are available. I request Dr. Babita also to talk about those also during her talk a little bit. Which ones are the good ones, and is there a risk of any kind of excess CPR or inappropriate also from some of the videos which are available on social media. And the studies have shown the mortality in India in due to sudden cardiac arrest. It's almost more than 4,000. It's 4,282 per 1 lakh population. So more than 60% of all cardiac deaths are basically because of that. And timely CPR can increase the chances significantly of survival. So that's why we should be aware of the recent techniques and knowledge regarding the CPR for all healthcare workers, for specialists up to the A&M level, including all workers in between. And that's why this session has been scheduled. Along with this, in fact, as per program, there'll be a session on rational prescribing and perils of polypharmacy, striking the balance and for safe and effective medication use, will be taken by Dr. Sangeeta Sharma, which also, we all should be now aware of what are the rational prescribing practices, because polypharmacy as such, and if you see the recent estimates from the Jan Aushadhi Pariyojana, which not only polypharmacy, the kind of medicines which we are giving to our public. The on the top is the pantoprazole and domperidone mix, and if you combine that with the figures of pantoprazole, so that's the largest number of selling drugs are these. And we all know the effect of these drugs, pantoprazole, these drugs on the renal system also in the long run. And similarly, if you look at the other medicines also, so that's why it's time that rational prescription should be a must in our daily practice as such. So just like we talk of quality and patient safety, and rational practices, of course, is part of that only. And it also is linked with the AMR, which is another issue which is of huge importance. And polypharmacy again, the bundle bus therapy and even combinations. So that I look forward to Dr. Sangeeta's lecture on that. I will not talk much. It's a very precious time for all of you who have joined online. I wish all the very best and all the success to this session. And there has been a session interaction also with you all with some kind of pre-test questionnaire, and there'll be questions and all also followed by post-test questionnaire. Please make it interactive. Ask questions in the chat box, and the organizers will try to give answers and all other, or even subsequently also you can link up with NHSRC or DSP ID to clear your doubts subsequently too. So with that, all the participants wish you all the very best, and thank you. I must thank you to join in on a Saturday afternoon at this time. regularly for this interactive series and important topics as such, and the feedback has been tremendous, very positive from all those who have joined earlier in the previous sessions. So thank you very much. All the best. Thank you.
Thank you, sir. Thank you for your words of wisdom. Now I request Dr. Sangeeta Sharma ma'am to take the session on rational prescribing under perils of polypharmacy, striking the balance for safe and effective medication use. Over to you, ma'am.
Thank you. Can you see my screen?
Yes, ma'am.
Some of you are not able to submit the form. It's open. You can try again. I don't know. I gave access to some of you who were saying that they are not able to open. They have accidentally closed the questionnaire. I have opened it again. You can try again submitting the questionnaire once again. Okay. While you are doing that, let me speak about. This rational prescribing and the perils of polypharmacy. How do we strike the balance for safe and effective medication use? Because the complexity of treatment has increased. Our population age has also increased. So as we are growing in age, there are multiple comorbidities are there in our patients, in older patients. So there is always a trade off between, how do you go about managing such people with minimum number of medicines prescribed. But as Dr. Atul Kotwal was saying, uh, this is a huge problem, because somehow over the years we have started believing in the power of medicines. Of course, medicines have been helpful. They help us in curing the disease, in controlling the hypertension, diabetes, epilepsy. There are lots of chronic diseases where we have been able to do a lot of improvement because of the medicines. But if we don't use them properly, they can be harmful too. So today I'm trying to give you the how do you balance between over prescribing and under prescribing. And as you know, rational use of drugs is, it requires that the patients receive medicines appropriate to their clinical needs. Whatever they needed, we need to give them in doses meet in that they meet their own individual requirement. That means if you need a liquid dosage form or inhalation or injectable or an oral form, you should be able to provide that dosage form. Similarly, for adults, if you need tablets, but for children you need syrups, suspensions, then those should be available. And for adequate period of time, whatever it is required for the cure of the disease or controlling, maybe some are required for lifelong. And the last part is very important, at the lowest cost to them and community. Whatever treatment that we choose for the patient should be the lowest cost. Many of us are not able to appreciate this in the public health system because we are not directly paying for it. But let me share with you that the medicines form a second biggest component of the health budget. After salaries, it is the 35 to 40-50% of the budget is spent on the medicines. So if we use these medicines inefficiently, where not needed, then it leads to inefficiency in the system due to wastage of this. And ultimately we are all paying for it in the form of taxes. But nothing in this world is free. Somebody is paying for this. So with this, I think this rational drug use medicines prescription, this was given in 1985. It is still relevant today, and I think it is even more relevant in today's scenario. Now, what does this the rational prescribing encompass? That we need to prescribe medicines based on evidence, not just because we have been using this, our past experience has been good. One example that was given by Dr. Atul Kotwal was domperidone with pantoprazole combination. If we needed only pantoprazole, then why are we giving domperidone along with it? Or if you can work with domperidone, then you don't need pantoprazole. But if we use these FDCs together, one of it is going as a waste. So there should be an evidence based selection of medications that will provide maximum benefit while minimizing harm. And we should be able to achieve the therapeutic goal. Is it to control the disease, control hypertension, bring sugar down to euglycemic level, or stop pain temporarily? And ultimately all these should be able to help us improving the patient outcomes and the patient safety. So, when you say rational prescribing, we need to take care of all these factors. We need to take care of the patient's medical condition, individual characteristics, and are there any potential drug interactions between whatever drugs that we are prescribing, and whether they are cost effective or not. Now, there is a term which is often used now, the polypharmacy. What is it? What do you mean by polypharmacy? Is it that when you use simultaneous medicines, multiple medications together, uh, particularly you call it polypharmacy when you don't the medicines prescribed are not as per patient's needs and conditions. They have been there just because for some time a drug was prescribed and then it was never discontinued, and there is a no longer need for that, but the drug is being continued. And especially this happens, we see increasingly more commonly in older adults, those with multiple chronic conditions. And why are we worried about this polypharmacy? Is because it leads to increased complexity of the treatment. I will show you prescriptions. Some drugs are given 3 times a day, 6 hourly, twice a day, before meals, after meals, before bedtime, like that. So there are several medicines, and there is an increased complexity. So patient get confused, and many times it leads to non-adherence, and of course the drug interaction, ADRs, and decreased quality of life. Now we are particularly, we are worried about with polypharmacies, the adverse drug reactions. As the number of drugs prescribed increase, it has been proven, there are lots of literature on this. As the number of drugs prescribed increase, the chances of adverse drug reactions are also increasing. Now these adverse drug reactions could be disturbing, could lead to hospitalization, and in many patients thus leading to increased healthcare costs, and sometimes death also happens because of the adverse drug reactions. Now, which are the groups of medicines where these are preventable? Now, why are we worried about this? Is because largely these are preventable, and particularly with cardiovascular medicines, anticoagulant. At the moment you see warfarin in the prescription, think about some drug interaction. This is the larger, one drug with largest number of drug interactions. Similarly, diuretics, because they also alter the electrolyte levels, fluid water level in the body. So again, think of some ADR happening with diuretics. Then hypoglycemic agent, they have been a boon for the diabetic patients, but at the same time, if you don't use them properly in proper dose, and if there are drug interactions which increase the level or decrease the sugar level, can be harmful. And of course, the non-steroidal anti-inflammatory drugs, which are very often very commonly used by many of us, also are responsible for large number of adverse drug reactions. Now, if you look at the another risk of polypharmacy, is that it can lead to drug-drug interactions. Many times you need these some of these drugs together, but then you need to adjust the timing of the medicine being given, so that this interaction can happen at the time of absorption, metabolism, excretion from the body, or it can happen as a pharmacodynamic interaction, because the two drugs being given together have the same effect. For example, aspirin and clopidogrel, or aspirin and warfarin given together, both have they affect the bleeding time if you give them together. Many times these are needed together, but then you have to be careful that there could be an interaction, and it can either lead to toxicity of the drug, or may reduce the efficacy. In general, this study reported that 10% of all prescriptions, it triggers a concurrent safety alert. So some of you may be thinking that it's not very common, but it is quite common. Drug interactions happen around 40%. Drug duplication, because many of times we are prescribing drugs by in a fixed dose combination, so same drug is being given, being present in two dosage forms, so duplication is there, or a wrong drug is being given for the age group, or a high dose is being given for the drugs which are not to be used in pregnancy are also used. So around 10%, and it's quite a big number that raises concern. Now, as I was telling you about the one of the greatest risk of polypharmacy is that medication non-adherence happens. This is because of the complexity of the regimen. Here you see, this is a real life prescription here. Although the patient has multiple comorbidities here, but you look at the number of drugs being given here: TDS, BD, OD, HS. Especially the elderly people, they become very confused. What all medicines to be taken, what time. So, and particularly if you have too many medicines and they belong to same groups, it can increase the risk of falls and frailty in elderly people. So in terms of the definition, polypharmacy exists when anyone takes five or more drugs daily in a continuous manner and for more than 6 months. So anytime any patient is on more than five drugs, do consider all these risks may happen in this. It may be appropriate. You may argue with me that multiple problems are there, so you need to give them. But just I'll take you through. Where is it? When is it that it becomes inappropriate? So whenever the bottom line is, you have to see that it should be as per the patient's need or medical condition, and it becomes inappropriate if there is no indication for this. For example, I have a prescription here. This patient is 64-year-old male, with COPD, with hypertension, with ischemic heart disease, and was on this treatment. On top of it, developed watery diarrhea for last 3 days. Now look at his prescription. 13 drugs have been prescribed to this patient. If you closely look at, some of these drugs are redundant here. You know Ethylene, derifylin is no longer recommended. Lasix perhaps for the hypertension or ISD part. Then for hypertension, amlodipine and alapril, ranitidine, prednisolone for COPD. Now you look at ranitidine and digene here. These are two opposite action medicines. Ranitidine works in acidic pH, and digene is an antacid. It makes the pH of the stomach basic, so you are neutralizing the effect. Now you look at tablet mononitrate is there, then brufen, because the patient may be having general body aches, B complex, and then for diarrhea, ciprofloxacin is there, flagyl is there. Now why two antibiotic and anti-emetic together? since it is only a watery diarrhea, 90% of the time it is viral in nature. You don't need antibiotic or anti-emetic agent. Now, flagyl, if you add to this regime, metronidazole again has introduction drug interactions, and it has its own adverse drug reactions. Even if the patient is not having vomiting, it will induce vomiting in such a patient, and makes the dehydration worse for these patients. So maybe you can argue, it's a complicated patient, so these many are actually needed. Now let's see another prescription. This is a young patient with abdominal pain, vomiting, and you look at the number of drugs. 5 drugs are there, and again, drugs with opposite effect. Ranitidine, digoxin is there. Perinom is stimulates the GI tract, increases the movement of GI tract, and buscopan slows down it. So again, the opposite action medicines are prescribed. Similarly, as I told you, metrozil has been prescribed. Maybe this is quite some time back. Nowadays, ornidazole, secnidazole, tinidazole like drugs are prescribed, which have lesser adverse drug reaction, but they all have nausea, vomiting as the primary adverse drug reaction. So, a patient who is otherwise not well, having abdominal pain, will make the situation, the condition of the patient worse with metronidazole. At least it wasn't needed here. Now, another scenario is, we often prescribe a drug, and the patient comes back to us, doctor, I've been taking this drug, and it is giving pain in my stomach. And reflexly, we give, another, because we rely too much on the power of medicines. And he said, no problem, I can prescribe another drug. I hope you are able to guess which drug would it be. I can't see you right now, but I hope you are all able to guess, what these drugs could be, which is this one which is causing pain in the stomach, and which is that we prescribe as a reflex. Painkillers are the ones, instead of giving them advice that you take it after meals, to reduce the pain in stomach. Reflexly, nowadays I see even the first dose of any analgesic drug that we give, a PPI, proton pump inhibitor, omeprazole or pantoprazole like drug is prescribed. Now the problem is, that the need for the painkiller may decline over a time, but the patient remains on these PPIs forever, and that complicates the problem. I think in one of the earlier sessions, I talked about the prescribing cascade, which leads to polypharmacy. That you prescribe, here is a patient, proteinuria and diabetic CKD patient, ACE inhibitor was prescribed to this patient. One of the known side effect of ACE inhibitor and telmisartan like drug is hyperkalemia. And when this hyperkalemia develops, we prescribe another thiazide or loop diuretic for this patient. Now, because of these diuretics, there is a worsening of diabetic control and uric acid level, because they diabetes, increase in sugar level and increase in uric acid is one of the adverse drug reactions of thiazide. So we add another drug for diabetic control, and we need to add another drug for the uric acid. Then because of these drugs, the patient, because now the excess dose of hypoglycemic agent has happened, patient may have more episodes of hypoglycemia or weight gain or salt retention. Then we intensify diet restriction and add another antihypertensive. So, and that further then leads to worsening of anemia, and then you need to give iron supplements. So that's how this cascade happens. We need to break this cascade. We need to evaluate the prescription from time to time to see if there is any drug induced effect or adverse effect. Is there anything that I can substitute rather than adding to this? On lighter side of it, you may say anything but this is the problem, and that's how the number of drugs in a prescription keeps on increasing. Sometimes the number of drugs are justified. For example, if you're using an opioid induced regimen somewhere, even tramadol, you may, because these patients will genuinely have some constipation, you may use laxatives, you may use antacids for painkiller induced gastritis. This may be justifiable, but probably what is not justifiable is anti incontinence drugs, oxybutynin, prescribed for nighttime incontinence in patients taking a diuretic at bedtime. If at all patient has to be put on a diuretic, the dose of the diuretic should be given before noon time, or otherwise the patient will have increased urination at night time. And especially if it is given to an elderly patient, if he gets elderly patient gets up at night, because there would be orthostatic hypotension, and they may have dizziness when they get up to go for a toilet, and they may fall, and then this fall can be fatal for the lot of brain injuries, fractures happen because of the fall. So this may be at root cause of it, maybe because the timing of the drug was not right. So always give diuretics before afternoon, so that increased urination that we want to happen passes off by night, the patient goes back to sleep. Similarly, in my hospital, in neuropsychiatry hospital, when you are trying to treat psychosis, you need to give antipsychotics, and one of the side effect of is extrapyramidal symptoms, and for that you will give trihexyphenidyl, anticholinergic drug. Now this anticholinergic drug in an elderly patient can cause confusion, can precipitate dementia like symptoms. Today only I saw one patient, because trihexyphenidyl was olanzapine was given, that patient had extrapyramidal symptoms. For extrapyramidal symptoms we give anti-parkinson drugs, and then these L-DOPA based regimens, they cause hallucination in this patient, and that was the cycle going on. And because the patient was on antipsychotic olanzapine, the patient became diabetic, pre-diabetic. So perhaps here trihexyphenidyl, which was introduced for extrapyramidal symptoms, should have been reviewed after time. We don't prescribe for more than 3 weeks, but in practice it doesn't happen. So perhaps then it becomes inappropriate. Similarly, when you prescribe drugs with similar mechanism of action, I gave you example of ranitidine and antacid. Ranitidine and even PPI combination, the same problem will be there, because they have opposite actions here. Then excessive medication duplication from the same class. There's no point if the patient is not responding to one drug from that class. Giving another drug from the same class will not help. Perhaps then you have to switch over to another class of medicine for treatment of that beta blocker. If you are not responding to atenolol, you will not prescribe be responding to metoprolol as well. Similarly, ACE inhibitors, or similarly the telmisartan or losartan, they are all same mechanism of action. There's no point in adding drugs from the same group. It will lead to duplication. Then inappropriate drug combinations with known interactions. There are prescribed that this should not be given together. Then medication induced adverse effect that outweigh the potential benefits. Overload happens, pill burden increases, it leads to non-adherence, and especially we are worried about elderly people who are at risk of fall. And third point, long-term use of short-term medications, benzodiazepines, diazepam, like these are very good sedatives and hypnotic agents used for inducing sleep, but we also know about their abuse potential. If given for more than 3 weeks, there are more chances of patient becoming dependent on this. So we always say that don't give them beyond 2 to 3 weeks, taper it or stop it. Similarly, alprazolam, is very favorite of the cardiologist. Anytime patient gets a angina, or they are stent is put, they are worried, they are anxious. So to relieve that anxiety, alprazolam is prescribed. Now this, the danger is that the patient will remain on alprazolam if not stopped in time. So, and once the patient become dependent, even if you become want to withdraw it, it becomes patient will have withdrawal symptoms. So long term use of short term medication should be avoided. And inadequate monitoring. I know we have a very heterogeneous group here. People from all levels of health facility are there. Medical tertiary care or quaternary care, warfarin is quite commonly prescribed. But if you do not monitor INR, even a good drug, warfarin, which otherwise can be made safe, can lead to side effect. Similarly, if you don't monitor blood sugar, you prescribe hypoglycemic agent, but you don't monitor, again it can lead to inappropriate polypharmacy, and of course it increases the cost. Now, most of the time when I speak to the prescribers, why do they write so many medicines, most of the time I get to hear that the patients come and demand for it. Now, my question to you is, can patients take all the blame for polypharmacy? Because this is a vicious cycle. When you speak to the patients, they say, I don't know anything. It was prescribed by my doctor. Since he has prescribed, I must honor his prescription. So and the doctor says, I prescribe so many medicines because patients expect. So this kind of vicious cycle continues and leads to misuse of drugs. So we need to be really very careful about what is it that the patient is asking for it. Don't I think, to me, it is more than a real, it's a perceived demand. It's not a real demand from the patient. We have made this notion in mind that the patients come and ask for it. Of course, there are risk factors belonging to the patient. As the age increases, as the morbidity increases, there is cognitive impairment, disability is there, and sometimes they are not able to see their primary care physician. Family physician concept has altogether disappeared. Maybe those with mental health problems are at more risk of getting large number of drugs, and those living in long term care facility like our hospital, there are chances, because they will keep developing some condition or the other. They may have more number of drugs prescribed, and those who are seeing multiple specialists, and they don't talk to each other. For your stomach problem, they are going to gastroenterologist, then they are visiting stroke for neurologist, then cardiologist. So there are more chances that the drugs get duplicated for this patient. Now, but as I said, it's not only the patients, it's the healthcare system also that supports or promotes, facilitates the polypharmacies. Poor medical record keeping, we don't know what all medicines the patient is being taken, who all specialists is he being visiting all the time. Poor transition of care, there is no communication after the discharge of the patient from the hospital. This patient, because he suffers from some adverse drug reaction, may get admission in another hospital. So there is no way of knowing what happened to the patient. And then sometimes prescribing is to meet disease specific metrics, and those systems where there is automated refill systems, they also, because it is medicines are filled automatically. Even if you have discontinued, it will be filled automatically. And doctor related factors which lead to polypharmacy are, sometimes we are not aware of, uh, what all side effects the drug may cause, or we may be very having a narrow focus on the specialty. As a gastroenterologist, I will looking at only the stomach, or as a cardiologist, I'm looking at only the heart part, but don't know about what are the other drugs being prescribed for this patient. So sometimes concerned specialist is also not referred. Why, we may question, I can why can't I prescribe it? There's no need he is also going to do the same thing, why not let me do it on my own? And poor communication with the patients, OTC medicines being taken, herbal prescriptions, and there are always people, there is lack of morality, because they are seeing the pharmaceutical representative to oblige them, more number of drugs are prescribed. And then many people think that if you are prescribing too many medicines, that means that you are not sure of the patient's condition, you're not sure what you are dealing with. So in a case of fever, you may prescribe anti-malarial, you may give antibacterial, and other drugs. It happens so often with diarrhea that we give antibiotic, we give anti amemic agent, we give probiotic, prebiotics to the patient, just because we haven't made the diagnosis here. So now these are the problems with the rational in polypharmacy. Now how can we control this? How can we promote rational prescribing? Of course, the first and foremost is comprehensive medication review. What all the medicines are being taken by the patient? All patients are also to be blamed to an extent. When they are seeing several specialists, they do not communicate the others the drugs or the problems being consulted. So they will bring your prescription only, they will not bring the cardiologist prescription, they will not bring the neurologist. So you have to ask for it specifically. They will not mention over the counter medicine, they will not mention herbal medicine. So you need to do this from time to time, and then individualize the approach, tailor their treatment according to their needs, preferences, and the goal. De-prescribing is one very very important strategy. I'll talk about this. And improving communication between the patient, and educate them, what are the do's don'ts, when to stop, not to stop, which drugs can be discontinued. All this is a part of the communication and the patient education here. Now, as I told you, comprehensive medication review, you need to talk about all the, get this information from the patient. This will tell you how many drugs are potentially interacting. Maybe there is a duplication, same drug being prescribed by different brand names, and it leads to overdose and harm to the patient. And of course, then you can reduce the unnecessary medication here. In America, it is popularly called brown bag review, because they dispense medicines in a brown bag. So they have a practice, they ask the patient to bring this bag every time when they visit, so that they know what all drugs have been being taken by them, and it allows them the opportunity to review their medicines. Now, de-prescribing, we are very good at stepping up treatment, and we do require stepping up of treatment as the patient's condition demands. Very good examples are asthma. They may need to scale up their treatment, step up their treatment. Epilepsy, diabetes, depending on their control, you need to step up treatment. But once the situation is controlled, once the asthma is controlled, seizures are controlled, we must make an attempt to de-prescribe. step down, uh, see which drug can be removed, so that the number of pills or the chances of interaction or inadvertent drug prescriptions are avoided, because unnecessary ones can be weeded out from here. So this can only happen when the regular review happens, but sometimes I understand there are challenges to deprescribing. Doctors, we are not able to spend enough time because of time constraints, patient load. We have hardly we have any time, or there may be a resistance from the patient, lack of systematic support, may hinder here, lack of comprehensive patient care plan. TB is another good example. We always had two phases, in intensive phase and continuation phase. Just because we were not writing this properly, intensive phase was being continued beyond 2 months. So plan was not written properly, that what is it that you would like to do. For pneumonia, that if you have given antibiotic, fine, it is needed for the patient, but then you must say that after 5 days or after 7 days I will review and see whether there is a continued need for an antibiotic or not. So sometimes some doctors feel that medicines prescribed by the previous physician, it would amount to contradiction of the original care plan, so they may be reluctant to do this. Of course, patients are also sometimes reluctant to discontinue. They fear, worry about worsening, so they may resist discontinuing. Then patient, I'm aware of one patient who was insistent. He was prescribed amoxicillin sometime, and then he continued taking it for 1 year. And the doctor kept complaining that I'm telling this patient again and again, but this patient is not stopping. Maybe there is some mental health issue with that patient, but resistance may be there. And sometimes, when there are multiple prescribers, one may be reluctant to stop the medications prescribed by another. Now, what do you do in such situation? We know that this challenge is existing. Maybe you cannot do it for all the patients because of the heavy patient load that you have, but then at least you can prioritize some patients for medication reviews, especially those who are on high alert medicines, those who are suffering from multiple comorbidities, especially 2 or more comorbidities, those who are taking 10 or more medicines. This is arbitrary, but I'm just trying to tell you that you can prioritize. If you have a limited time, you can prioritize those who have dementia, those who are frail, or palliative care situations. These are the situations where there are chances that polypharmacy may happen, and especially if you are dealing with the elderly, because they are at risk of polypharmacy. They may have other preventable problems like depression, constipation, falls, immobility, confusion, hip fractures. So especially look for deprescribing in elderly patients, because as they age they become dissimilar. They have there may not be direct correlation between disease severity and the compensatory mechanisms in the body. Some may be symptomatic, some may not be symptomatic. There are a lot of physiological changes in this group because of the pharmacokinetics. We had a session on prescribing in elderly. So they may have, after 60 years of age, there may be a decline in pharmacokinetic parameter, which would need dose adjustment. So it doesn't mean that earlier he was tolerating, he will continue. So the same dose can lead to toxicity. So because the kidney handling capacity has changed, so you may need maintenance dose adjustment. This can be done by reducing the dose, or you can increase the prolongation, or you may have to do both. For example, if you want to prescribe gentamicin to a patient who is having impaired renal function, what do? Normally you give it 8 hourly, so you may reduce the interval. You may say, I will now give it 12 hourly instead of 8 hourly, or you may reduce the dose, or you may have to do the both the things depending on the kidney function. So consider these things when, because they may have hypoalbuminemia, so toxicity may occur. So pH may also affect the impact of many of the drugs. Then there is a decline in stress resistance and resilience with the age. So disease presentation very often is atypical in elderly age group, especially those above 70 years. So you need to be, the presentation may also entirely be different in this age group. For example, mild hyperthyroidism can present as heart failure. Mild hyperparathyroidism can present as heart failure. Prostatic and mild enlargement can present as urinary retention. So, because this happens because of the decreased physiological reserve, symptoms develop at an earlier stage of the disease. So, similarly, those who are presenting with fever or electrolyte imbalance, um, and if they have the cause of this fever is urinary tract, so the moment you control, the infection is controlled, there will be a remarkable improvement here. Otherwise they may present with delirium, dementia, depression, incontinence because of this. So sometimes the other extreme may also happen. You may find many abnormal findings in elderly people. Bacteriuria may be there, but no symptoms. Then ventricular premature complexes may be there. Bone mineral density may be, impaired glucose. So there may be these findings there, but patient do not have any problem. So general, the dictum here is that you don't treat asymptomatic patient here. It may not reflect the disease, it may be an incidental finding, and altered pharmacokinetics makes them susceptible for more number of ADRs. So they may be sensitive to, oversensitive to some drugs like benzodiazepines, opioids, antiparkinsonian, anticoagulants, or they may be less sensitive to some drugs like beta adrenergic agonists. So there may be more drug interaction ADR. You may otherwise may not see these ADR, but constipation will be there. Diuretics, postural hypotension, antihistaminics may lead to sedation and confusion. So be aware of these ADRs in this group. There are other physical dimensions because of the limited mobility, because of the cardiac disease, or they may have reduced vision, accommodation, decreased hearing. So all these are special problems. Here is another case of acute pain and depression with asthma. This 57-year-old had a back pain, depression for 2 years, asthma since childhood, lost his job after breakup of marriage. His BP was 150/80, electrolytes were normal, peak flow rate was 300, slightly less. She's a smoker, and see the number of drugs prescribed to this patient: lansoprazole, beclomethasone, gabapentin, tramadol for the pain, mirtazapine for depression, salbutamol for asthma, zopiclone maybe is having sleeping issues. So all these there. So you can apply these 7 steps here. What matters to the patient? You need to review the diagnosis and identify what is it that you want to do. Is there a need? I say identify essential medications. which should not be stopped without specialist advice, or also evaluate whether there is a continued need for medication. Can you switch to SOS, or can you switch to a drug which can take care of two or three problems, whether the drug being given is effective or not. Then you need to withdraw. In epilepsy, we have to add other drugs if the breakthrough seizures happen, but then attempt also should be made to withdraw the earlier drug which was not effective, so that pill burden is reduced. Then review safety, cost, centeredness. If you do that, you can de-prescribe. There are other point of care resources for de-prescribing. One of the important handy tool is minimize the number of potentially inappropriate medication. These are called PIMS, which are responsible for the majority of the adverse drug reactions. So Bayer's criteria, they have identified these PIMS here. So if any drug which is on this list, you can be careful, such as amitriptyline, benzodiazepines, antihistaminic agents, muscle relaxants, antispasmodic. So you need to be very careful with these. Then another criteria I spoke about in my earlier session was stop criteria. How do you this is a screening tool. If you find these drugs in the prescription, be careful. Or maybe then you need to find out alternative for this. For example, if Senna or Bisacodyl is there for the prescription, you may have to switch to fiber here, because this Bisacodyl can lead to obstruction and ball perforation. Similarly, start criteria. This is a screening tool to alert doctors to write treatment. Proton pump inhibitors should be reserved for severe GERD patients. For patients over 80 years old or on antiplatelets, perhaps if you want to give some laxative, constipation problem, fiber supplements are better than the stimulant laxatives. There are several such examples. I will urge you, all of you have access to internet. You go and look for the stop criteria and criteria and Beers criteria. Take a printout, put it under your on your table, whenever, so that you can have a quick reference to this, and whenever you see these patients, you know what to do, and what are the suitable solutions. So we need to be worrying about medicines, because they are double-edged swords. On one hand, save life, but can be dangerous too, can lead to ADRs. And so we have a lot of technology and tools for rational prescribing. Electronic health records can help you keep a record of all the medicines being taken. Clinical decisions support systems can alert you for drug duplication, dose, contraindications here. And then something, medication reconciliation. I know I have people today in the room from the district hospital, CHC and PHCs as well. Medication reconciliation does not need any technology here. All you need to do is that you, from time to time, update the list of medicines being taken by the patient. At least do it 3 times, at the time of admission, at the time of discharge, and once the patient is moving within hospital from one ward to another, ICU to OT, or OT to ICU, or ICU to ward. So at transition point, medication reconciliation does not cost anything, but it is a very, very powerful tool to avoid errors and duplications. As far as possible, have multidisciplinary collaborations. Talk, pharmacists, nurses, doctors, if they talk to each other, we can improve. At least coordinate the care transitions, follow up and monitor these patients. Now, another powerful tool to control polypharmacy is the professional guidelines and standard treatment guidelines. The standard treatment guidelines tell you step up of the treatment and step down of the treatment. I gave you the example of asthma here. So these come handy here. So standard treatment guidelines can also help you. If this standard treatment guideline will also tell you which drugs are indicated, which are not necessary, which have a doubtful efficacy, or which are contraindicated. So if you go by the standard treatment guideline, polypharmacy can be restricted. And now I think many of you are returning participants here. I need not go into the depth of it, but the concept says these are disease oriented mini manuals focusing on the treatment, and it reflects the consensus on the treatment of first choice of treatment for priority medical. It's not a textbook. So they talk about the priority diseases only. And one of the now a lot of government guidelines are there. NHSRC has prepared 12 standard treatment guidelines for 12 diseases. Now ICMR had come up with 100 and more guidelines. National programs have treatment guidelines. So all of these guidelines are there to guide us. This one that I am showing here was the first one, comprehensive guidelines, which was first developed in 2002. Here we talk about 330 priority diseases belonging to 20 specialities here. So the feature of all of these guidelines is that they are meant to be reader friendly, comprehensive, evidence based. They provide algorithm approach, and patient education section is very important here. Although these are called guidelines, we need to be following this. They are not the law, but we have enough reason to deviate from these guidelines. Lot of we see lot of litigations these days, lot of violence is happening more so, and there more and more patients are taking doctors to the court on the pretext that there was some medical negligence, or I wasn't given the right treatment. So these STG come as a rescue for you. They'll help you if your treatment was in line with the given in the standard treatment guideline. I have seen many judgments where the doctors have been exonerated from it. But if you have no reason, I did one study, many of them say, I feel more autonomous, it's my professional liberty that I need to do it, I must decide for my patient. Then there are chances that people may get into trouble. But standard treatment guidelines are there to help you in two-thirds of the more than two-thirds of the patients, 75% of the patient, they'll help you. In atypical patients, yes, you can deviate from the standard treatment guideline, but by and large try and see that 75% 80% of the time you adhere to the standard treatment guidelines. So all of these guidelines tell you the brief introduction, give the salient features, the diagnostic, presenting signs and symptoms. Investigations are also very important, like irrational use of medicine is there. Similarly, there is an irrational diagnostic use is there. A lot of time we see patients are asked, investigations are asked which were not necessary, or the test is not confirmatory, does not help us, or the timing of doing that test wasn't right. So all of these are covered in the salient features. In the treatment part, non-pharmacological treatment is as important as the pharmacological treatment. Many a times I've seen that we are very quick to start with the medicines, but for example, if you're treating hypertension, if there is no lifestyle change, if the patient continues to take high salt or alcohol or smoke, does not exercise, do you expect any change in his hypertension? No. Similarly, diabetic patient, you may put them on right medicines, but if there is no diet control, there is no portion control, there is no exercise, so non-pharmacological treatment is as important. And many of us do not assess the response to therapy, which is also equally important. Sometimes we overdo it, sometimes we underdo it. So how often should you test sugar, how often should you get done x-ray done in pneumonia cases? All these things are covered in the standard treatment guidelines. Patient education, and of course these are based on reference here. Drugs are chosen based on the criteria of efficacy, safety, cost, and suitability. Since told you, patient education is very, very important. Many a times I was just reading a book day before yesterday. It says, many a times it's a myth. We think that we have communicated with the patient. The fact is that we hadn't talked about it. So, and many times for various reasons we don't listen to the patient, but they are an important part. We must empower them, listen to them, and if they are empowered, they will be in a better control of the condition. They should know. So for us, for a comprehensive practice, we there are a lot of hospitals are heavily regulated places. Similarly, now the prescriptions are also becoming heavily regulated, so we need to be following laws, requirements, rules, standard here. So all of this can be closed, can be done if we have standard treatment guidelines adopted in our practice. It will reduce inappropriate practice variation, improve safety, quality improvement, and it will help in knowledge translation. So ultimately, it is a human right now, access to essential medicines, but over prescribing and under prescribing will hamper with achieving this goal. And drug use is the end of the therapeutic consultation, so we must be very, very careful when we are writing prescription. And as a healthcare professional, all of us have a responsibility to ensure that the right drug is prescribed, dispensed, and taken by the patient. So I think with this I stop. Next session would be on poisoning, and I'll be talking about medicine use in renal and hepatic impairment. How do you make dose adjustments? If there are any other topics, you can write in the chat box, then I can consider including that in the next sessions. I think with this I can stop here. I think it was right on time.
Thank you, ma'am. Thank you for your session.
Okay, you can introduce Dr. Babita is waiting.
Yes, ma'am. We'll share, ma'am. The next speaker is Dr. Babita Gupta. She is a professor in Jaiprakash Narayan Apex Trauma Center, Department of Anesthesiology, AIMS, New Delhi. Ma'am has more than 75 publications at international and national journals on anesthesia. She is also an author of textbook called Essentials of Trauma Anesthesia and Intensive Care. Ma'am is going to take the session.
Annapurna, your voice is gone.
Okay. Sorry, ma'am. Our next guest speaker is Dr. Babita Gupta. She is a professor of Department of Anesthesiology at the Jaiprakash Narayan Apex Trauma Center, AIMS, New Delhi. Ma'am is going to take the session on cardiopulmonary resuscitation, quality, improving cardiac resuscitation outcomes. Ma'am also has 75 publications at international and national journals on anesthesia. She is also an author of a textbook called Essentials of Trauma Anesthesia and Intensive Care. Over to you, ma'am.
Thank you, Dr. Annapurna. It's indeed a pleasure to be a part of NHSRC, and I'm thankful to Dr. Sangeeta Sharma and Dr. Annapurna. Take so much efforts on a Saturday, which is a weekend, and all of you must be, are you able to hear me?
Yes, yes.
I'm thankful to both Dr. Sangeeta Sharma and Dr. Annapurna to give me an opportunity. So I'll start right away. Dr. Annapurna, can you share the slides?
Sure, ma'am.
The system here is, just give me a sec because the MacBook is not allowing. I've been trying.
Is
Yeah,
it audible?
yeah.
Screen can be seen by you, ma'am.
Yes, yes.
Yes, ma'am. Thank you.
Thank you, Dr. Annapurna. So I'll be talking on cardiopulmonary resuscitation. As the term suggests, cardiopulmonary resuscitation. So we are talking about the heart as well as the lungs. And this is very important because cardiopulmonary resuscitation is required not only in hospital but sometimes also out of hospital. The mortality is very high, almost up to 90%. If the cardiac arrest is outside hospital, the chances of survival is only 10%. And that too, this data is from other countries, from Western countries, where they have a very good pre-hospital care system. They have got well-equipped ambulances. So even if you take up that data, that is 90% mortality, still it is very high. We don't know the mortality, what is the mortality in out of hospital cardiac arrest, but it may be the same or even more. Regarding in hospital cardiac arrest, again the chances of survival almost up to 50 to 70%. Hence, it's very important for us to give cardiopulmonary resuscitation not only early but also effectively. So let us see what is cardiac arrest. Cardiac arrest is sudden stoppage, sudden cessation of mechanical activity of heart with some or no electrical activity. So even if there's some electrical activity, but there's no pulse, that means there's no mechanical activity of the heart. The heart is not pumping and the normal circulation has ceased. And because of that cessation of normal circulation of blood, due to failure of heart to contract effectively, there is no perfusion. However, it may be reversible by rapid intervention, which but will lead to death in its absence. So if you don't intervene, the patient will die, but it may be reversible if you take active intervention timely. And for this cardiac arrest, we need to undergo cardiopulmonary resuscitation. Can you go on to the next slide? So what is cardiopulmonary resuscitation? It is emergency life-saving procedure performed when the heart stops beating. And it combines the chest compression often with the artificial ventilation. It may be with advanced airway or without advanced airway, in an effort to manually preserve the intact brain function until further measures are taken to restore the spontaneous blood circulation and breathing in a person who is in cardiac arrest. And it is not just one component but multiple components which has to be given together and in a series, and each component is linked with the other. Go to the next slide. I'll be talking about basic life support and advanced cardiac life support. Basic life support is mainly talked about by a lay person or a healthcare professional, but outside hospital when you don't have the sophisticated gadgets along with you. So, life support and advanced cardiac life support. Adult basic life, I'll quickly brush through the adult basic life support. The adult basic life support, the first part you have to do is, if supposing you see a patient on the road or anywhere outside the hospital, the first point you have to see is that you have ensured a safe place, that the scene is safe. That is, if supposing there's a fire going on, or there's a building already an earthquake and the building is rumbling down, that is not the time that you should be entering in. So first you have to see whether it is safe for you as well as for the victim who has suffered the cardiac arrest, or who may require cardiac arrest, is not in cardiac arrest. So first thing you have to see is that whether the place is safe. And if it is not, go to the next slide. Then patient has to be shifted to a safe place. This I'm talking about the basic life support, which may be outside hospital. I'll quickly brush through the basic life support and then go on to the adult advanced cardiac life support, which is being given in hospital. So you have to ensure the basic thing, that is, verify the scene safety and bring the patient to a safe area. The next step which you will do is check for the responsiveness and shout for nearby help. Nowadays we have smartphones, so you can quickly put on the speakerphone on the mobile, and simultaneously you can do the steps of CPR and call for help. Call for help either to you can shout for help to nearby people, or you can even call on the phone with the speakerphone on, and activate the emergency medical services. And at the same time, tell them to get an AED and the emergency equipment. How to check for the responsiveness? Next slide. Check for the responsiveness just by tapping on the shoulder from front and ask loudly, "Hello, hello, how are you?" Or in the language wherever you are, either in Hindi or whatever local language. "Hello, hello, how are you? क्या आप ठीक हैं?" If the patient responds,
You are not audible.
Call her and find out, Annapurna.
Okay, ma'am.
She's calling. Hello.
आप दिख रहे हैं बट स्क्रीन नहीं दिख रही है.
You can speak. Start, Dr. Babita.
Yeah, but I'm unable to see the
Screen.
Yeah.
Maybe your
Can I do one thing? I'll start my PPT and simultaneously you can exhibit that CC.
Yeah.
I think that will be better.
Yeah.
Can I do that?
आप अपने स्क्रीन पे अपनी प्रेजेंटेशन खोल लीजिए. Here Annapurna can match with your
Yeah.
you can
Yeah, I think that will be better. Yeah. So ensure in trauma, do not move the patient violently. Just tap on the shoulder from front and ask loudly, "Hello, hello, how are you?" So there can be three kind of responses. If patient responds, fine. There's, you can just, go ahead with the next step. If the patient response starts talking, you need to monitor the patient. But if the patient doesn't respond on your shouting, then look whether the patient is breathing or not, and simultaneously look for the checks, look for the pulse. Check for the pulse simultaneously, and this should be done not more than 10 seconds. So how do you know whether you're checking the pulse for 10 seconds or not? It's a very rough way, but 1 second, if you say 1001, it is around 1 second. So you have to check the pulse, but not for more than 10 seconds. If you are doubtful whether the pulse is there or not, then you understand that you take it for granted that the pulse is not there. Do not check for more than 10 seconds. Now, once you have checked for breathing and pulse, then there can be three different scenarios. Let me tell you how to check for the pulse. So you keep two fingers middle of the neck, and then roll your two fingers on the lateral, from medial to lateral, and in the groove, you check for the pulse. If there is normal breathing and the pulse is felt, there can be one situation. If there's no normal breathing and the pulse is felt, that could be the second scenario. And there's no breathing and there's no pulse. There are three different scenarios we'll face: normal breathing, pulse felt; no normal breathing, pulse felt; no breathing, and no pulse. So in case there's normal breathing and pulse felt, just monitor the patient until the emergency responders arrive. Until that time, keep the patient in lateral position. Just roll the patient and keep the patient in the lateral position. So that was the scenario when there is normal breathing as well as the pulse is felt. Monitor until the emergency responders arrive. Second scenario could be no normal breathing, but the pulse is felt. So this patient is in respiratory arrest because the pulse is felt. So there is cardiac activity and there is enough mechanical activity. The pulse is felt, but there's no normal breathing. So you have to assess the respiration. In that case, you can provide rescue breathing, that is 1 breath every 5 seconds or 10 breaths every minute. Approximately 10 to 12 breaths can be given per minute. Check for the pulse every 2 minutes. If no pulse, start CPR. If possible, overdose, which is common in Western countries, then naloxone can be administered. However, this may not be available at the scene, but minimum thing you can do is just give artificial breathing. This is a bit controversial, especially post-COVID. That's why the AHA has come out with the guideline that hands only CPR can be given. You just give chest compression, which is the most vital part of the CPR. Even if you can't give breathing, you at least give chest compression. The IRC, that is Indian Resuscitation Council, also talks about calls, that is compression only life support. If it's your near and dear relative, definitely you should go ahead with mouth to mouth respiration. However, if you are not comfortable, if you cannot give, then at least give chest compression in case the patient requires. The third scenario is no breathing or only gasping, but pulse is not felt. Remember, if the patient has agonal respiration, it is not effective enough. So you consider that the patient has respiratory arrest. No breathing and only gasping pulse and pulse not felt. Then you have to go ahead with the CPR. Start CPR, that is start chest compression, and perform the cycles of 30 compressions and 2 breaths. 30 if you are single rescuer, 30 compression, and then come at the head end, or you be on the side of the patient, give compression and give 2 breaths after every 30 compressions till the AED arrives. And use the AED as soon as it is available. The emergency medical responders, or if you are in an area where AED is available, like airport, etc., then you have to use AED as per the instructions. Chest compression part I'll deal with in adult advanced cardiac life support, because the chest compression skill remains the same whether it is basic life support or advanced cardiac life support. Once you have started CPR, perform cycles of 30 compressions and 2 breaths. Use AED as soon as it is available. Once the AED arrives, the AED will prompt you whether the rhythm is shockable or not shockable. Even if you are not able to diagnose, and if the AED says that it is a shockable rhythm, give one shock. Do not waste much time. Resume the CPR immediately for 2 minutes. The AED will prompt you that 2 minutes are over, and then again you have to check for the pulse and keep on continuing the CPR till the AED prompts you that you have to give shock. If the rhythm is not shockable, then you resume with the CPR immediately for 2 minutes. That is, just give cardiac compression. You need not give shock over here, and continue until the ALS providers take over or victim starts to move. The victim starts responding. Okay, so this was the basic life support without any advanced gadgets, which you can give outside hospital. And in case there are, if it's a very small center where nothing is available, then at least you can start with the basic life support till you get advanced cardiac life support from somewhere, the providers as well as the gadgets. What is advanced cardiac life support and what is the goal? So the goal of ACLS, which we do, is as per the AHA guidelines, that is American Heart Association, which has given the guidelines and recently updated in 2020. And this has been done after a lot of research and the studies. Goal of ACLS is to achieve best possible outcome for individuals who are experiencing a life-threatening event. And it is a series of evidence-based responses, simple enough to be committed to memory and recalled under moments of stress. So they have been made very simple, and it's an algorithm that one to be done after the other, and all the complex things have been removed from the guidelines in 2020. The ACLS protocols assume that the provider may not have all the information needed from the individual. That is, we don't know whether the patient is acidotic, we don't have any information whether the patient is hypothermic, whether he has taken opioid overdose or some drug has been administered. The first only thing we have to do is just provide cardiac life support. But the guidelines have been based that we don't have much information, and you have to provide them CPR. And for that, you need to know the chain of survival. That is, one key has to meet with the other, and they have to be in continuity. So the chain of survival in adult in hospital, chain of survival, it is early recognition and prevention, activation of emergency response, high quality CPR, defibrillation, post cardiac arrest care, and the latest they have added is recovery in 2020. And this has been done because AHA believes that cardiac arrest survivors need support during recovery to ensure optimal physical, cognitive, and emotional well-being and return to social and role functioning. This component, the recovery part, has been added just in 2020 for better quality of life to the patient. Adult in hospital and out of hospital chain of survival is slightly different. And in hospital, it is early recognition, pick up the early warning signs. And in out of hospital, it is activation of emergency responses. Rest all components almost are similar. In hospital, it is high quality CPR followed by defibrillation and post cardiac arrest care. Let us come to the adult advanced cardiac life support. As soon as you diagnose that the patient has got cardiac arrest, start CPR. So this patient is in hospital. You should be able to provide oxygen in some way. Either it is bag mask ventilation, or the patient, if the patient is already intubated, put him on PiO2 of 1, that is 100% oxygen. So provide him oxygen in some other way, and attach monitors and defibrillator. Now the patient is in hospital, monitor would have been available. Attach the monitor and defibrillator. Although all these things are written one after the other, but all these things are done simultaneously. That is, you provide oxygen, attach monitor, simultaneously one person is taking IV and the other person has already started the chest compression. So you start CPR and give chest compression. For chest compression, what is the procedure? Elbows should be straight. Do not bend the elbows, because that will cause easy fatigability, and it also decreases the efficiency of the chest compression. And the sole important component of cardiopulmonary resuscitation is chest compression. Even if you are not able to give ventilation for some time, and that is what the guidelines have been changed. Now it is CAB. Previously we used to talk about ABC. Now this chest compression is one of the most important component of cardiopulmonary resuscitation. So provide chest compression with elbows straight, shoulders above the victim's chest, fingers interlocked, and the palm should be over the lower part of the sternum. So you join both the line from the nipples, and then join a straight line, and the point where they intersect, you have to, at the lower end of the sternum, you have to place your hands interlocked with elbows straight. And allow complete chest recoil between compression. Do not lean on the patient without lifting hand from the chest. Do not stop chest compressions unnecessarily, because it is important to release the pressure after each chest compression, so that you allow the chest to expand completely. Only then it will be effective in the next cycle. Let the heart fill up blood so that it is ready for the next pump again. What are the components of the high quality CPR metrics? As per the AHE guidelines, the chest compression fraction, at least in more than 80% times, it should be effective. Like chest compression fraction should be effective for almost 80% of the time. So whatever we are saying, that more than 100 to 120 per rate, it should be there for more than 80% of the time. The compression rate should be 100 to 120 per minute. Again, this is a rough guess, because while giving CPR, it will be difficult for you to count. But if you can count that 1, 2, 3, 4, then you will get an idea that 100 to 120 per minute the rate of chest compression is being given. And that's why you perform these acts in on mannequin, or by mock drills, and you'll realize that at what rate 100 to 120 per minute compression are giving. Rotate the compressor every 2 minutes, because as I said, giving effective cardiac compression, you'll get fatigue. If you rotate the compressor and the person who is at the airway end, the effectiveness increases. Compression depth of at least 2 to 2.5 inches in adult is required, and at least 1/3 of the chest in children and infants. Avoid excessive ventilation, because positive pressure ventilation will hamper the venous return and cardiac output. If there is no advanced airway, then 30:2 compression and ventilation ratio can be given. However, in case the advanced airway is there, 10 per minute RR can be given. Quantitative waveform capnography, if the capnography has been attached, then you can see the capnography, and at least EtCO2 of 10 mmHg should be there. in case it is less than 10 mmHg, then you need to improve the CPR quality. ETCO2 is a rough indicator of the perfusion of the heart and the lungs. So ETCO2 of more than 10 mmHg should be there for you to realize that you are giving effective cardiac compression. In case the patient already has intra-arterial line, then intra-arterial pressure, and if the diastolic pressure is less than 20 mmHg, again you need to improve the CPR quality. So you have to maintain ETCO2 more than 10, diastolic pressure more than 20 mmHg. Once you have given the CPR, that is the oxygen is being delivered, you have attached the monitor, you have started giving chest compression. Next thing you have to see is whether rhythm is shockable or non-shockable. If the rhythm is shockable, it could be either ventricular fibrillation or pulseless VT. VT, there are two types of VT, that is pulseless VT and VT with pulse. VT with pulse is a different scenario, but VF with and pulseless VT both are cardiac arrest. They both the situations, treatment remains the same. How do you recognize the ventricular fibrillation? When you see the ECG, they both look slightly different, but both of them are ventricular fibrillation. The first ECG strip, you see fine ventricular fibrillation. So there's chaotic rhythm. You cannot recognize P wave. You cannot recognize QRS complex. You cannot recognize T wave. It is fine ventricular fibrillation. The second ECG, again there's chaotic rhythm. No P wave, no QRS complex, no PR interval, no T wave. This is coarse ventricular fibrillation. Again, the treatment remains the same, whether it is coarse ventricular fibrillation or fine. So if you are not able to recognize what it is, at least if you know that this is ventricular fibrillation, then go ahead. This is shockable rhythm. Go ahead with the shock. Second condition is pulseless VT. Pulseless VT, it looks more organized. However, since it is pulseless, it is not effective for the heart to beat effectively, and hence there's no perfusion. In ventricular tachycardia, unlike the ventricular fibrillation, the RR interval are usual, but not always regular. Atrial rate cannot be determined. As you can see in the ECG, there's no atrial, there's no P wave, so you cannot determine the atrial rate. QRS complex is not preceded by P waves. PR interval is not measurable. And QRS complex, it may measure more than 0.12 seconds. And the treatment remains same as ventricular fibrillation, that is shock. So if it is shock, now you have to defibrillate patient. So get the defibrillator. What kind of defibrillators are available? Either they are monophasic or biphasic. And whenever a fatal arrhythmia is present, CPR can provide to some amount of blood. So whatever chest compression you are giving, it will provide some amount of blood flow to the heart and brain. But it cannot directly restore an organized rhythm. So there's a lot of chaotic rhythm going on, and it requires some shock to organize the rhythm. There are multiple foci in the heart, which is throwing out ectopics in the there are multiple foci in the ventricle, which is throwing multiple ectopics for it to cause chaotic ventricular rhythm, which is ventricular fibrillation or ventricular tachycardia. Hence, you need to give a shock, and just chest compression will not be enough. The purpose of defibrillation is to disrupt this chaotic rhythm and allow the heart's normal pacemakers to resume effective electrical activity. Whatever normal pacemakers are there, that is SA node is the pacemaker which controls the heart rate, and of course the other conduction system. So that is what the role of defibrillation is, the shock is, that it organizes the disrupted chaotic rhythm. How to apply the paddle? One paddle is kept, as you can see in this picture, on the right side of the sternum, and the other is kept laterally. So this is how you have to place the paddles. Put on the machine, place the paddles, adjust the energy in the defibrillator. What energy has to be given? As I said, it is different for biphasic and monophasic. Biphasic, the difference is that energy which is flowing is from one end only in monophasic, and that's why higher current is required. While in biphasic, the current which is flowing is from both the ends, and hence the current required is less. In monophasic, it is 360 joules, while in biphasic, it is 120 to 200 joules, depending on the manufacturer recommendation. So each machine will have around 120 or 200 maximum, and monophasic will have 360 joules. Suppose if you don't know what kind of defibrillator it is, then go on to the maximum energy set on the defibrillator. Just go on to the maximum setting. If it is biphasic, the maximum will be 200. If it is monophasic, it will be 360. So it is safe for you. And why nowadays the defibrillator has biphasic shock energy? Because now the current is flowing from both the ends. So you need to give less of current, and the myocardial damage is lesser as compared to monophasic. That's why nowadays all the defibrillator are by and large biphasic. So this is the shockable rhythm. Once you have given the shock, while giving the shock, you have to give clear-cut instructions. I've applied the pad. The shock has been set to 200 or 360 joules, whatever it is. I'm clear. You are clear. Everybody is clear. The person who's giving the shock sees that everybody is clear from the bed and delivers the shock. As soon as you have given the shock, again, continue the CPR. Do not give excessive interruption in the chest compression, not more than 10 seconds. Immediately continue with the CPR. If you are not taking IV access till now, take the IV access. And once you've given 2 minutes of CPR, again, check for the rhythm. Shockable, again, go ahead with the CPR. And now, but this time, the difference is, along with the shock, you are giving epinephrine. That is adrenaline. Okay, now how do you prepare adrenaline? 1 ml of adrenaline is 1 mg. Whatever is available in the market and in the hospital, 1 ml is 1 mg. It may be written 1 in 1000, which means 1000 mg in 1000 ml. So 1 ml is 1 mg. Right? So you have to give 1 ampule, that is 1 mg. How do you administer? Either you can administer direct 1 mg, just load the drug 1 ml from the ampule and flush with 20 ml normal saline or ringer lactate and elevate the hand. Do not forget to elevate the hand. Normally we do not elevate the hand, but in this case we need to elevate the hand because there is no circulation going on and the drug may not reach the heart. You have to flush the drug and then elevate the hand. The other way is you just prepare in 20 ml saline, but that may take some time. So just give the drug 1 mg and elevate the hand after flushing it. So the second cycle after the shock, you have given epinephrine, and this you will keep on repeating every 3 to 5 minutes. Consider advanced airway. Advanced airway could be either supraglottic airway device or intubation while you are giving CPR, chest compression. Again, check for the rhythm after 2 minutes. So every 2 minutes, you have to keep on doing that. If it is shockable, continue with the shock. Continue with the shock. But this time, second time, the first time we gave epinephrine. This This time we're giving impedes. Impedes comes in 3 ml ampule. That 3 ml is 150 mg. So 1 ml is 50 mg, 3 ml is 150 mg. Loading dose is 300 mg. You have to give 2 ampules stat as a bolus, just as we gave adrenaline. 300 mg impedes. Flush with 20 ml. Whatever drug you give, you have to flush. Flush with saline or ringalactate, elevate the limb. While you are doing all this, treat the reversible causes. I'll talk about it in the other slides, but you have to simultaneously think why the patient sustained cardiac arrest, why the patient must have, there could be any toxicity, whether drug was given, whether any toxins, whether it was cardiac tamponade, whether it is pneumothorax, tension pneumothorax. So simultaneously you have to diagnose and treat the causes if you are able to diagnose. So if we are clear with the shockable rhythm, we'll go ahead with the other rhythms which are there in the adult advanced cardiac life support. Okay, if the patient, I'll again go back. If the shockable rhythm now turns out to be non-shockable, then we go on to the other limb. That is asystole or pulseless electrical activity. What is asystole? Asystole is flat line, and even if there's some erratic activities which may be there because the heart is just quivering, it is just there's some activity going on, but not enough for it to pump. So again, you consider it as asystole. But before diagnosing, make sure that your ECG electrodes are in place, there's no equipment failure, because the management is slightly different in asystole. In asystole, it will be flatline, no rate, no P wave, no QRS, no PR interval. Any rhythm which is flatline or any rate or no rate at all, it is called asystole or PEA. PEA is pulseless electrical activity. If you have any doubt whether it is pulseless electrical activity or not, just palpate the central pulses and see. If there is a pulse, so it is not the emergency situation for you to give CPR. Then look, you have to go ahead and think of other causes. Right now we are dealing with CPR. It is a pulseless electrical activity. So go ahead and continue your CPR. You were giving chest compression. You have diagnosed that it is asystole. This you give epinephrine as soon as possible and keep on giving CPR and epinephrine every 3 minutes. Epinephrine has to be given every 3 minutes and CPR has to, after every 2 minutes, you have to check whether the rhythm is shockable or not shockable. And this cycle continues till either patient becomes, is resuscitated and there is pulseless activity, there is a pulse, or the rhythm from non-shockable, it becomes shockable. Then again, you have to give the shock. So once if there's no sign of return of spontaneous circulation, you continue. But in case there is ROSC, that is return of spontaneous circulation, you have to go to post cardiac arrest care and continue the resuscitation in ICU later on. As I said, the CPR, whenever you're giving CPR, you simultaneously rule out the reversible causes of cardiac arrest. They are hypovolemia, that is, it could be because of trauma, hemorrhage, hemorrhagic shock, which has caused the cardiac arrest. It could be hypoxia. It could be acidosis, severe acidosis, hypokalemia, hyperkalemia, hyperglycemia, hypoglycemia, or severe hypothermia. Or it could be 6Ts, that is thrombosis, which is MI, thromboembolism, tension pneumothorax, cardiac tamponade, trauma, or any tablet which has caused anaphylaxis, overdose of any drug. These are the reversible causes, and you have to treat the cause as soon as you diagnose it. In the algorithm, we had advanced airway. So as per the AHA guidelines, you can either insert the tube or supraglottic advanced airway. Whatever airway device you use, you have to make sure that you're competent enough to insert. Don't use supraglottic airway device in an arrest situation, in an emergency situation, if you are not comfortable with it, and if you don't have expertise in it. You can intubate the patient. Even if you can't intubate, just continue with bag mask ventilation. Look for waveform capnography to confirm and monitor the ET tube placement if you have inserted the endotracheal tube. And once the advanced airway is in place, give one breath every 6 seconds, that is 10 per minute, with continuous chest compression. The drugs which we use, so in cardiac arrest, shockable and non-shockable, both we are using epinephrine, that is IV, 1 mg every 3 to 5 minutes. One person is taking care of the time, that 3 minutes have elapsed and you have to keep on giving epinephrine. You keep on continuing. There's no time limit when to terminate. Keep on giving epinephrine. And in the first cycle of shockable rhythm, you have to give epinephrine. First one we gave shock. Second, we have to give epinephrine. Other drug which we use in CPR is emidaron. That is in EFVT, that is shockable rhythm. The first was epinephrine. Second time now we give emidaron, 300 mg bolus, and second dose will be 150 mg. The first dose was 2 ampules. Second dose is 1 ampule. Instead of emidaron, if it is not available, you can give lignocaine. That is Zylocard. Not the lignocaine which we use as local anesthetic, because that has got preservative. You have to use the lignocaine without preservative. So the dose is 1 to 1.5 mg per kg. 1 ml of lignocaine contains 20 mg. So you have to calculate the drug and give 1.5 mg per kg. Second dose will be half of it, that is 0.5 to 0.75 mg per kg. Remember, emidaron and lignocaine, both the first doses, the second dose is double, is half of the first dose. Okay. So now you have resuscitated the patient. ROSC has come back. Post cardiac arrest care has to be given. Otherwise, whatever efforts you have done, they may be lost. So you have to give as per the AHA guidelines, you have to give therapeutic hypothermia. The temperature which has been mentioned is around 32 to 34 for at least 24 hours. And so recommended for comatose patient with ROSC after cardiac arrest event, individual should be cooled to 89.6 or 93.2, which is around 32 to 34 degrees centigrade. Oxygen should be titrated to achieve pulse oximetry more than 94%. Maintain the oxygenation. Do not overventilate, because as I said, positive pressure ventilation can decrease the venous return. Plus, it can cause cerebral ischemia. So just ventilation to maintain normocapnia, that is 35 to 40 mmHg EtCO2. Can give IV fluids, and vasoactive medication infusion can be started to maintain the hemodynamics of the patient. If indicated, if it is MI, PCI is preferred over thrombolytics. Neurologic care, specialty consultation should be sent for neurologic assessment. This is the post cardiac arrest care algorithm. ROSC has been obtained. You have managed the airway if the tube has not been inserted, and now you have an expert. So insert the endotracheal tube because that is the definitive airway. Maintain the parameters, as I said, 92 to 98 degrees saturation. Obtain 12 lead ECG and rule out STEMI or unstable cardiogenic shock. If required, then advanced care has to be given, that is some kind of mechanical circulatory support like IABP, etc. If the patient starts obeying your commands, follows the command, then just continue with other critical care management. If he doesn't, then continue with the hypothermia management, obtain advanced radiologic investigation like brain CT, EEG, and the critical care management as per the condition of the patient has to be given. It's very important for the team to work in sync, as there has to be one team leader who organizes the group, monitors the performance of the team members, able to perform all the skills, should be expert in performing all the skills, directs the team members, and provides positive critiquing the group performance after the resuscitation effort. Whether the patient has returned back or not, we need to have a assessment of a CPR at the end of the resuscitation effort. What is the role of team member? They should be able to understand the role, should be able to follow the team leader's commands, willing, able, and skilled to perform the role, understand the ACLS sequences, and be committed to the success of the team. It's very important to have effective team dynamics. So whatever one person is communicating, the other person has to reply back. So there has to be closed loop communication. Supposing I say, give 1 mg adrenaline. The other person administers 1 mg adrenaline and says, 1 mg adrenaline given, flushed with 20 ml saline, I am elevating the limb. Chest compression, one person is giving chest compression. You keep on counting. The other person is, timing whether the 3 minutes have elapsed or 2 minutes have elapsed to check the pulse or to check the rhythm. The messages should be very clear. 1 mg adrenaline, if it has to be diluted, give 1 mg followed by 20 ml saline. The roles and responsibilities of each person should be well defined. Should know one's limitation. Don't go on to advanced management which you are not expert for which you don't have expertise. Knowledge sharing, very important. Constructive intervention. If someone is going wrong, okay, give effective compression. No, you're not giving effective compression. Press hard, press fast, no recoil, press effectively. So constructive intervention should be there, and keep on reevaluating it. But while doing that, we need to have mutual respect for each other. So this is the 6-person high performance team. You may change the roles as per the availability, but if you have 6 person, you can define the roles of each person. That is, one person giving chest compression, second person giving defibrillation, third person managing the airway, one person team leader who just monitors, is not directly involved in the resuscitation. One person takes care of the IV, and the 6th person takes care of the timing. To terminate the resuscitation, so as per AHA guidelines, supposing if the arrest was not witnessed, there was no bystander CPR, there's no return of spontaneous circulation, no shock was delivered before transport. All the criteria are present, you can consider termination of resuscitation. If any criteria are missing, then continue with the resuscitation and transport. Now, one question which is always asked is, how long to continue with the CPR? There's no well-defined time interval for how long to give CPR. We have seen patients. There was a patient who came from Nepal. 4 hours CPR was given. He came from a cold area, and patient was M6. GCS was full after CPR. So 4 hours, and they didn't give up. So that is what the message given, that not give up, and there's no time limit. Pregnancy in hospital cardiac arrest, everything else remains the same except that perimortem cesarean delivery can be performed if there's no return of spontaneous circulation in 5 minutes, and this has to be performed within 5 minutes, and there should be no delay, because at least you are saving one life, and with that you may even save the mother, because maybe that is the cause that is causing aortic cable compression. So that is the only difference. Otherwise, rest all remains the same. And you have to rule out the potential causes of maternal cardiac arrest, which are almost the same, but apart from other causes, it could be anesthetic implications, bleeding, cardiovascular, drugs, embolic, fever, or hypertension. This is the tachycardia algorithm, adult tachycardia with pulse. So you don't need chest compression, but you'll have added this because this does come in advanced cardiac life support. So assess for the appropriateness for the clinical condition. If the heart rate is more than 150 per minute and tachyarrhythmia is there, so identify the treatable causes. If the patient has got symptoms like hypotension, acutely altered mental status, signs of shock, acute heart failure, then you go ahead with the synchronized cardioversion. In the latest guidelines, the synchronized cardioversion, different joules shock energy has been deleted, and now it is just small energy current which has to be given. If regular narrow complex, then consider adenosine. And supposing the patient is not symptomatic, then you go ahead and see whether wide QRS is there. If wide QRS is there, then adenosine only if regular and monomorphic, and anti-tachyarrhythmia infusion can be started, and you need to take expert opinion, that is cardiology consultation. If wide QRS is not there, then attempt vagal maneuver and adenosine beta blocker, calcium channel blocker, and again consider expert consultation. The synchronized cardioversion, the paddles and etc. remain the same. Only thing is a smaller energy is being used, and it has to be in sync. So there is a button on the defibrillator where you can just turn the sync and it will synchronize on its own and deliver the shock. You may have to give slight sedation because now the patient has got pulse, he is alive. Adenosine, remember, it has to be given rapidly. 1 ampule is 6 mg. Give IV and then flush with normal saline. If the patient doesn't respond, then give 12 mg. So that was the tachycardia algorithm. Bradycardia algorithm, again, identify and treat the underlying cause, give oxygen, IV access, attach 12 lead ECG. If the patient is symptomatic, that is hypotension, acutely altered mental status because of bradycardia, and if there are signs of shock, then give atropine. Again, I would like to highlight that the atropine which is available with us is 0.6 mg. What AHA advises is 0.5 mg. So there's not much difference. You open 1 ampule and give 0.6 mg. Okay. Give atropine, and if atropine is ineffective, then you have to pace and start dopamine infusion or epinephrine infusion. Consider expert consultation for transvenous pacing, call a cardiologist. But if there is bradycardia, but if the patient is asymptomatic, you need not do anything actively at that moment. Just monitor, observe, and if the patient becomes symptomatic, then you go ahead with the further treatment, as I said, that is atropine and TCP, dopamine, or epinephrine. So let me summarize that VF, VT, and pulseless VT are shockable rhythms. Asystole is non-shockable rhythm. Effective chest compression is the most vital part of CPR, and team dynamics is essential for CPR. Thank you very much. And for any queries, you can contact me at this email address, that is drbabitagupta@hotmail.com.
Thank you, Dr. Babita, for your detailed description of how to manage CPR, both at basic life support and ACLS. I hope participants were benefited. I was looking at the pre-test and the demographics of the group today. We have more than 400 people in the room, but majority of the participants today are nurses. So I was little surprised, but that shows the commitment that the nurses have, because they are also part of the team, resuscitation team. Uh, and now I can request the participants, if they have any questions, they can ask the expert here. She's with us. Uh, Annapurna has also put up the post-test questionnaire in the chat box. But while you are doing that, I would suggest that you utilize this time. And if you have any questions, difficulties, the common observations, maybe meanwhile, they are writing. Dr. Babita, can I ask you, what
Yeah,
are the
sure.
common problems that you find where the CPR goes wrong? What should be done, you have very well explained. But in practice, I have seen many people panicking, at that time, even if they know you have trained them well, but they panic and some things go wrong. So what is it in your experience you find that one should be really very careful about?
Okay, the first thing is that the bed has to be on a firm surface. Okay, so whether it is BLS or ACLS, wherever you are giving CPR, it has to be on a firm surface. Many a times I see that the mattress, if it is very soft and it is air filled, this is I'm talking about ICU. Air mattress is there. It has a function of CPR that you can deflate within few seconds. So you have to deflate. Number one. Secondly, you need not the latest guidelines also mentions that you need not shift the patient anywhere else if you have to give CPR. Many people they think that we have to for firm surface we have to shift the patient to somewhere else. So the mattress which is available in the hospital is firm enough, if it is not air mattress, for you to provide CPR. The second thing I would like to highlight is that the bed, if you can increase or decrease the height of the bed, you should adjust it according to your height, so that you are almost you are above the patient. So if supposing you are very short and you cannot bring down the table, you can climb on the bed and you can give effective CPR. Most of the time, just by standing, it will be enough. Third thing is that do not bend your elbows. After some time, many people they start bending their elbows because they get tired, and that is the importance of changing the position for effective chest compression. Uh, and adrenaline, 3 minutes, every 3 minutes it has to be given. Many times everybody becomes very enthusiastic, and they keep on repeating after every 1 minute or 1.5 minutes. So you need to have some time sense. And the other thing is recoil. Many hefty males, they may think that effective chest compression is you press as hard as possible. As I said, not more than 5 centimeter. It is not required actually. And as you when you are giving at a higher depth, the recoil also suffers. So you effectively your chest compression has not you is not optimal. These are the various things, and for all these, the prevention of all this, just to perform mock drills. Practice on a mannequin. I'm not able to hear you. Please unmute yourself.
Sorry, I had muted myself. Yes, I think practice makes the man perfect, and the role of each member in the CPR team. If you practice, then only it will be clarified. Otherwise, people will be taking on the role of others, and there is a confusion who is going to do what. So I think, and the record, I think you've already mentioned. CPR is also done, many a times I've seen that they do it properly, but there is no record or documentation of what was done in CPR. It's very important to go back and review what happened to the patient, how was the CPR was conducted, how long did it take, what problems were encountered, then only we will be able to sort them out in the next event whenever it happens. I've seen, this is again a real life story. CPR teams come, they do their job, revive the patient, go back, and next day patient again gets into CPR arrest, cardiac arrest, because there was, the CPR team did not try to find out why did this arrest happen. And in this case it was a preventable cause, because this patient was on nasogastric tube, was being given labetalol, nifedipine, and one nitroprusside. And because the patient was on nasogastric gastric tube, this extended release nifedipine was crushed and given by the nasogastric tube. And as a result, patient had a profound hypotension and had a arrest. CPR team came on the first day, revived successfully, went back. Next day again, because nurse never knew that she was not supposed to crush this extended release nifedipine, because all the nifedipine was released at once here, because she did not know, she did the same thing, gave the dose again by the nasogastric tube by crushing this. And this time the patient was not lucky enough to survive this second cardiac arrest in a 2 days in a row. So the importance of communication, trying to find out why did this arrest happen in the first place, is also very very important if we want to prevent this happening in future. uh, in fact, I believe we should not allow the any arrest to happen in hospital setting. I think Dr. Babita will agree. We should actually try to find out, who are the patients who are likely to get into cardiac arrest. Rapid response teams, warning signals must be there in most of the time. Sudden cardiac arrest, I think Dr. Babita can
I would like to just add, whenever we say that suddenly patient को कुछ हो गया and arrest हो गया, so I always tell my resident doctors, this was, although you saw it suddenly, but it didn't happen suddenly. There must have been certain early warning signs which you all didn't see. So definitely there were some signs which were not taken care of timely, and that's why the patient has got cardiac arrest. It's not that sudden cardiac arrest out of blue ho gaya. It is that you didn't see, you just saw suddenly. So there are early warning signs, and you should
Can
anticipate.
you, Dr. Babita, can you highlight the early warning signs? Because most of the nurses are here with us. They are closer to the patient. Patient के पास रहती हैं.
Definitely.
So what are those signs that they should be getting cautious, or must trigger a response from them so that arrest is averted?
Yeah. So as I said, major H's and T's. If you think in that direction, first is airway. If the patient is and hypoxia and hypotension, these are the two commonest causes of cardiac arrest. So if the patient has got hypoxia, supposing the patient saturation is less than 92%, these are the early warning signs. If the patient is not breathing well, he is tachypneic, don't wait for the patient to desaturate rapidly. Pick up these early warning signs, like the RR is more than 30. Patient's pattern of breathing is not normal. That is, normally we breathe thoracoabdominal, but now he started using his abdominal muscles. Now he started using his sternocleidomastoid, alien is flaring. As he started breathing slightly in taking more efforts. One is rate, second is the pattern. and use of accessory muscles. The desaturation will occur slightly later. So if the oxygen is going on, saturation may be more than 95%. But these are early warning signs. So that is as far as hypoxia is concerned. Second, shock. It could be any kind of shock. It may be hypovolemic shock. If the patient is post-operative, there'll be tachycardia. Tachycardia could be because of hypoxia also, but tachycardia due to hypovolemia. And there, if the patient is in the post-operative care unit, there's a drain which is, which has got blood collecting from the chest tube drain or abdominal drain, whatever the surgeon has inserted. Maybe he's bleeding, or maybe if there's no drain, maybe he's bleeding from somewhere, which you need to find out. So hypotension, BP is going down without any reason. In a post-op, it could be bleeding, or in a medical ICU, a medical ward, it could be some other cause, like it may be MI. So all these are early warning signs. If the patient has got fever, maybe he is going in sepsis. Fever, flushed face, capillary refill is not normal. So all these are early warning signs, which I wanted to highlight.
Yeah, I think with if you can recognize these early warning signs, we can avert a lot of cardiac arrests in hospital at least. And another, I think you did touch upon this, the duration of CPR.
Yeah.
I think this is again a very, very controversial. People don't know, but this is important. Can you just once again emphasize on duration? How do you assess that whether you will continue with CPR or you won't?
Yeah, as already said, there's no guideline per se how long we need to continue. And in my own experience, I've seen that the patient, if even after 2 hours of CPR, there was ROSC. So there's no guideline. It in the Indian resuscitation guidelines, the calls, it is for out of hospital. They've mentioned that there's no advanced cardiac care support, and there's fatigability. So you can, okay, or the rigor mortis has already set in. Then maybe yes. Uh, I would say this is off label, what I'm saying, but probably severe traumatic brain injury when the patient is already dead, or then maybe terminally ill cancer patient where palliative care is going on. Again, it is not there in the guidelines, and it's more of the team and the relative saying that okay, let the patient go. But again, this is what I'm saying is off label, and it's not incorporated in the guidelines. Depending on
Especially
the patient.
I've seen, this was in news, a small baby, I think 20 weeks, that happened in one of the hospital in Delhi. He was declared dead and he was handed over to the family while they
Literally
were,
started open.
burying the child, and the heartbeat returned, because things like this keep happen, but general public thinks that there was negligence, but these are real life difficulties that you can't make out.
Yes, it's very important to confirm that there's actually no. Maybe the child had some activity which was not picked up. So you all these monitoring devices, they do have role. If there's no electrical activity, maybe the patient had electrical activity. Otherwise, there
In
would
that
be
case, I
no.
think the fetus was below viability age, and hypothermia is very common, and hypothermia can lead to decreased
Yeah,
electrical.
exactly. That's what I was talking about, the patient who was flown from Nepal. He was hypothermic. So 4 hours resuscitation, and then the patient's GCS was full, and it was because he was hypothermic. So there are no certain guidelines per se.
But one should be, if there is hypothermia, then I think
It should
extended
be prolonged.
CPR
It
would
should
be
be
helpful.
should be prolonged. Definitely.
Yeah. And then one thing, there was one question about recovery position. The answers were not very good. Can you just, explain once again on the what should be the recovery position, and why is it important to maintain the recovery position after CPR?
Okay, and actually the recovery position was for a patient who is, who has pulse and who is breathing and responsive slightly, or maybe even unresponsive, but there is pulse and there is breathing. It's not for the patient for whom we have given CPR. So that we need to understand. In case the patient doesn't have pulse, we have to give chest compression and supine position. That is the position for chest compression. In case the patient doesn't have breathing, you have to provide ventilation. So the recovery position is given only for patients who has pulse and who has breathing. It has to be given in lateral position. Lateral, which lateral? Again, there is no particular left lateral or right lateral. Whichever position you can give, you can give right lateral or left lateral. The hand of the patient was shown in the picture. Hand of the patient will be up, and the limb which is up, the lower limb will be folded at the knee joint. The limb which is above will be folded at the knee joint, and the lower limb which is dependent will be straight. So that is what will maintain the position of the patient in lateral position. And this is given so that whatever secretions or even if vomitus is there, it will come out, because the patient is not fully conscious, his sensorium is not on. So that is the recovery position.
I think she has addressed all aspects of CPR today, and I don't see any question in the chat box. I presume that all your queries have been answered. And with this, we must thank Dr. Babita to spare her time and come today and share her experiences with us. Thank you, Dr. Babita. We look forward to your
Yes,
continued support.
one thing which you were asking me that many people had query. This is the adrenaline ampule.
या हाँ कंसंट्रेशन कैसे बनाना है दैट्स दी हाँ
तो इसको कुछ नहीं करना. This is one ampule. This is 1 mg. You just have to break the ampule and fit stat concentrated. Okay, it's written 1 in 1000. Forget what is 1 in 1000, 1 in 10,000. Just give it stat. Okay, and flush it with 20 ml normal saline. Even if you want to dilute it, you can dilute in 10 ml saline, but you can flush it with 20 ml. The idea is to give 1 mg. And how much to dilute, it's not mentioned, it's just 1 mg. You give 1 mg. This is amidaron, 3 ml ampule. These are the only 2 drugs which are used in cardiac arrest situation. So just remember these 2 drugs. This is 150 mg. First dose of drug which you will give. First time you gave shock in shockable rhythm. Second time you will give epinephrine. Third time after shock you will give Codron. 2 ampules stat, 300 mg. So that is it. And second dose you give 150 mg.
One thing I think when you showed the ampule reminded me, beware, ये look alike होते हैं. Adrenaline and atropine vials are look alike vials, and CPR के समय I've seen people panicking. They pick up atropine instead of adrenaline, and that is the cause of death actually. Marking of these drugs, labeling of auxiliary labeling of look-alike sound alike drugs is also very important. So all crash carts, everywhere, wherever these crash carts are there, one must label these adrenaline, because it has a look-alike. And similarly, another problem that is seen from medication management point of view is, adrenaline has a short shelf life, 6 months to 1 year only, and it is rarely required. These arrests don't happen so often. There are patient care areas where it happen more often, but in hospital, in certain areas these don't happen. So what happens is, when you actually need them, वो expire हुआ हुआ होता है. तो इसलिए every month you should conduct an audit and look for, if there are any drugs, आपकी क्रैश कार्ट में कोई भी दवाई expired तो नहीं है. So you need to replace these drugs from time to time, so that when you need them, you have them ready with you. Because CPR, as ma'am was saying, आपके पास कुछ मिनट का ही टाइम है, 3 से 5 मिनट का ही टाइम है. जितना जल्दी आप इंटरवीन करेंगे उतना सक्सेसफुल होंगे. अगर आपको एड्रेनलिन ढूंढना पड़ रहा है, यू हैव टू आस्क फॉर इट, वो एक्सपायर्ड नहीं दे सकते हैं आप, तो यू विल लूज दिस प्रेशियस टाइम. तो आई थिंक nurses are here with us today, so they should take care of look-alike labeling उसकी है, and there are no expired drugs on your crash card.
One more thing, yeah, that's a very good point you have talked about. Look-alike के labels लगा दो crash cart में. Second thing which you have to do is, जो भी आपका hospital है, all the drugs should be standardized. They should be kept in a standardized way all throughout the hospital. तो ये ना हो कि एक में एड्रेनालिन फर्स्ट ड्रॉर में है और कहीं और जब हम जा रहे हैं सीपीआर के लिए तो थर्ड ड्रॉर में है. So that has to be standardized. Secondly, there has to be big bold labels for all the drugs wherever you're keeping, whether it is adrenaline or atropine. There should be big labels and look alike, sound alike, as mentioned.
क्वांटिटी भी इम्पोर्टेंट है. कई जगह पे मैं जाती हूँ असेसमेंट में, कोई लोग 2 एम्प्यूल रखते हैं, कोई 5 एम्प्यूल रखते हैं. अब 2 एम्प्यूल वाले के साथ हो सकता है कि पैनिक करते वक्त मैंने देखा है कि वो वाइल ब्रेक भी हो जाती है, एम्प्यूल ब्रेक भी हो जाता है. देन यू आर लेफ्ट विद नथिंग. तो हैव एन एडिक्वेट. इज देयर एनी क्वांटिटी विच इज रिकमेंडेड दैट should be kept in the crash cart?
This is not mentioned in any of our books, but as per the NABH guidelines, they say at least 30 to 40 ampules should be kept.
How many? Sorry, I missed that.
At least 20 to 30 ampules should be there of these emergencies.
In each crash cart?
Yes, yes.
तो मतलब डेफिनेटली 2 या 5 से काम नहीं चलेगा, बिकॉज कई बार हम यूज कर लेते हैं और रिप्लेस नहीं किया है, तो देन अगेन यू विल नॉट हैव एनी एड्रेनलिन लेफ्ट इन योर क्रैश कार्ड. सो देयर शुड बी सफिशिएंट नंबर ऑफ एम्प्यूल, एंड दिस शुड बी स्टैंडर्डाइज. शी राइटली मेंशन्ड, एक तो प्लेस स्टैंडर्डाइज करें कि कहाँ कौन से ड्रॉअर में रखना है, क्वांटिटी स्टैंडर्डाइज करें कि कितना क्वांटिटी हम रखेंगे, लेबल करें, एंड देन रेगुलरली डू ए ऑडिट फॉर एक्सपायरी डेट कि ये सब चीज़ें क्वांटिटी, प्लेस, और दीज थिंग्स आर मेंटेन्ड और नॉट. आई थिंक अगर CPR का ऑडिट करेंगे तो एट द रूट कॉज यही चीज़ें ज़्यादा मिलती हैं कि वो एड्रेनलिन नहीं था, या एड्रेनलिन ढूंढने में टाइम लग गया, या ट्यूब ठीक नहीं था, या डिफिब्रिलेटर काम नहीं किया उस वक्त, या वी डिडंट नो हाउ टू यूज ऑपरेट दिस डिफिब्रिलेटर. So all these things are all important, and I think nursing staff have a very important duty. They are entrusted with this task of maintaining the crash cart. So at least this part can be taken care of easily and prevent mishaps happening in the hospital. I think there are no more questions. Thank you, Dr. Babita, for coming over, sharing your experiences with us. We look forward. Deepika, do you want to say anything?
Thank you, ma'am. Thank you so much. And It was quite informative session, ma'am, and I think all people are able to be benefited from this particular session. And there is one glitch took place today from our side. Somehow the chat for the participants got disabled. That's why you are not able to see any of the questions. But we are putting up our email ID. If there is any question that has not been answered today, then ma'am, we will bother you once again, like if you can, answer that questions, because few of the answers we have noted down, so we will make a kind of answers for that section and get it available for different.
Okay, thank you, Deepika. Post-test, I'm looking at the number of responses received. We have received around 270 responses, whereas I think we had more than 400 participants here. Pre-test was given by 365 people. Those of you who want the certificate, please fill up the post session questionnaire also. Otherwise we will be constrained not to issue. So please, दोनों pre और post जिनका दोनों होगा उन्हीं को certificate मिलेगा. So please, I hope you are able to open the questionnaire link and perform this. As you submit the responses, correct answers will appear on your screen, and explanation for that also will appear. So maybe you can go through that, read it later. uh, at least make sure that you have opened the post test link now. You can complete it at your convenient time later. I will keep the form open for some time, but don't take it too much of time. Zyada time mat लीजिएगा. Try to do it now and save the responses. It will tell you the correct answers. I think post as today we had almost 80% participation from Goa.
Okay, ma'am. Okay.
I
Thank you,
was
ma'am.
just looking at their distribution. So I don't know what's the reason, but because we earlier we were not asking this question.
Yes, yes.
Uh,
Now it is there, ma'am. I also observed it. Many place from the state also we are asking it now.
Now
Thank you,
at
ma'am.
this time I've added this,
Yes.
to know where from our participants are coming. But today I think it's Goa. This color is for Goa. Yes. And then others are also there, but major participation is from Goa. So any specific order in that state?
Look into it, ma'am. Thank you, ma'am. Even on behalf of NHSRC and DSPRUD, I thank Dr. Babita Gupta, ma'am, for providing the valuable knowledge and quality cardiopulmonary resuscitation. And I also thank for Dr. Sangeeta, ma'am, for the continuous support and taking the technical sessions on every lecture series. Our next lecture series is on 15th of July on poisoning topic, and also on the medicine use in the renal and hepatic failure. Uh, so this session will be recorded and it will be shared in the YouTube channel of the QPS team. For the and we apologize for you for disabling your chat. It is by mistakenly it was disabled without knowing to us. So you can ask the questions through the email ID which we have shared in the link, and also you can ask the questions in the YouTube YouTube channel of our QPS division. So we try to answer through mail and the YouTube channel. And
One more thing, yeah, Annapurna, feedback. Not many people are providing the feedback.
yes, we have shared even feedback link also in the link in the chat box. Please provide your feedback, and you can even provide your topics which you want for the next lecture series through the mail. Also, you can send us that whichever you want the topic, a dedicated topic to be learned from our side. We are going to look into it for the topics also, because only last two it was left for the sessions which is completed by the August. from later onwards we have to decide the topics for the next year. Please provide your feedbacks even on that also. Thank you, ma'am. Thank you, Dr. Gupta Gupta, ma'am. Also, those there are some glitches today with the internet and other issues, but we supported you very well with the IT team. And I also thank for the participants. Without you, it is not possible to conduct the lecture series for the every month. And to conduct this lecture series, our Major General Professor Atul Kotwal sir, Executive Director, he is the backbone for us to conduct this session. And also I thank Dr. Jain Srivatsav sir, Advisor QPS Division, for supporting us to conduct this successful lecture series since 10 months. Thank you, ma'am. Thank you for your support.
I must thank Annapurna and Deepika for all the support. They are the ones who are managing it at the back end, without any this thing. So thank you, Annapurna and Deepika, for that.
Thank you, ma'am. We are going to end the session now, ma'am. Next, again, we will meet on the 15th of July.
Sure.
Thank you all.
You can share this feedback link through email. They can, if those of who haven't, done now, they can, do it later.
Okay, ma'am. Sure, ma'am.
Okay, bye bye. See you
Bye,
next
ma'am.
month. Yeah.
Thank you, ma'am.